Welcome to Season 4 of Inflammation Nation. My name is Maebh Coyle. Inflammation Nation is a podcast from Arthritis Ireland aimed at increasing awareness and understanding of arthritis and related conditions. I'm delighted to welcome Dr. Jo Kitchen to this episode today to discuss medications and arthritis. Jo is a rheumatologist who specialises in diagnosing and managing a variety of rheumatic conditions. Her medical interests include RA, musculoskeletal ultrasound, and advanced biologic therapies. She strives to enhance the quality of life for her patients through evidence-based practices and cutting-edge therapies. Jo studied medicine at Trinity College Dublin and undertook her rheumatology training in Ireland, completing an MD at Trinity College before completing a fellowship and master's in advanced medicine at the University of Barcelona. She worked at the Royal Berkshire NHS Foundation Trust for 10 years before returning to Ireland to join the Mater Hospital, where she now works as a consultant rheumatologist. Jo, thanks so much for joining us today to discuss this important topic.
Thanks so much for having me, Maeve. It's great to be here.
Great. So let's get started with we have a very interesting round of questions and very detailed. So let's just kick off with the first thing I'm going to ask you, Jo, is just to give an overview of the more recent medications that have been used to treat arthritis. I know this has kind of changed the landscape and the outcomes for people living with arthritis today. I know when it comes to the terminology, one of them is DMARDs, which refers to disease modifying. And I just wanted to ask you, with these new medications, how far can disease actually be modified to the point of being dampened right down?
Well, I suppose the last 20, 30 years in rheumatology has been a really exciting time for patients with inflammatory diseases such as rheumatoid and psoriatic arthritis, amongst others, because we really have had a whole new host of additions to our medication. So I suppose going back to the start, we have older medications like methotrexate, which are still very much first line, but the way we use it in early rapid escalation of treatment can get a lot of our patients under control with that. But then also over the last 20 years, we've had the advent of biologic drugs targeted to small molecules and other therapies, and really in terms of how we approach the disease has really changed on its head, where we aim to get people treated early and into what we call remission, where there's minimal signs of disease activity or any symptoms. So in terms of disease modifying, really the aim is that we target the inflammation and that we really switch it off so that it drops back down to an undetectable level, which means that we don't get inflammation and damage in the joints and that our patients have an optimum quality of life. So it's been a really exciting time and there's more things on the horizon.
So Jo, without getting too technical, if that's possible, could you give us some insight into how the medications actually work in terms of targeting individual cytokines, B cells and T cells, for example, and the impact that this can have on the immune response?
Yeah, so I suppose historically some of our drugs would have had a broader general dampening down effect on the immune system and control that inflammation, whereas some of these newer biologic drugs, as you've mentioned, have a specific target. So I suppose the first one that would have been available to us would be targeting a cytokine called TNF-alpha. So we have these anti-TNF drugs and they're used across our inflammatory diseases and can mop up all of this inflammatory molecule that is around the circulation of our patients. We also have other molecules that target different other cytokines. So tocilizumab would be one that targets a cytokine for IL-6, which can work for some patients. And then alongside these individual cytokine targets, we also have medications that work on a different part of the immune system called the B cells. And this would be drugs called rituximab that would dampen down that side of the immune system. And that's used in rheumatoid arthritis and in some other conditions. So there's varying targets within a very complex and ever increasingly complex immune system, the more we understand of it. And at the moment, there is some trial and error with which patient is going to respond to which drug. But as we move forward with this, and there are some pointers already as to knowing which patients may benefit from most from which type of targeted therapy, if that's what they need.
Great, that's really interesting. And Jo, a lot of our listeners will be aware of the term kind of generic drugs, brand names. Also, they will have heard about patents, biologics, biosimilars. can all be a little bit confusing. Could you just give us a little bit of insight into how that all works, please?
Yeah, sure. So obviously, historically, normal drugs like, I suppose, paracetamol and ibuprofen would have brand names like Panadol and Nurofen. And these were the original drugs. The companies have spent money marketing them, advertising them, and you pay a slightly higher price. They're the originals to market. Whereas if you go in to buy a generic version of paracetamol or ibuprofen, it's the same medication exactly. You're getting the same compound, but it just doesn't have a brand name attached. It doesn't mean it's in any way any less efficacious, but it's just often at a better price point. So similarly with the biologic drugs, these originally were obviously very high cost technical drugs to develop in the first instance. And so most of them will have normally a 10-year patent when they come out. And they are called the originator biologic drug. But once that patent runs out, you have other companies making these medications. They're not allowed to be called generics because it's a biological molecule. So they're called biosimilar. And they are very similar. There's no difference in them. It's not that they're an inferior product. They are just made by a different company. So it's just effectively a different brand. So originals wouldn't be proven to be better than the biosimilars, and there's been studies backing this up as well.
And they do tend to be cheaper, obviously.
They do. So it's best value biologics, and obviously in the health service we want to make sure that we can get access to as many patients as possible who need these drugs. So it's a win-win for everyone.
Okay, Jo, and then could you tell us about when you're prescribing medication? I know that drugs to treat arthritis are often used in combination. So you might hear that somebody's been treated with methotrexate and hydroxychloroquine at the same time. Like, how are these combinations decided upon, or how often are combinations used these days?
So combination treatment would be pretty common. In Ireland, we would adhere to national and international guidelines, particularly the European and sometimes the American guidelines in terms of how we manage medication and how we escalate things. So in rheumatoid arthritis, for example, the first line drug is methotrexate. And that is what drug most patients would be started on unless there's a reason for an alternative. And then the international recommendations would be that you then would add on either a conventional DMARD drug, which are the older tablets, or that you would look to add in a biologic drug. And we know that combinations of drugs work very well for patients. If the one drug isn't quite getting them into remission, sometimes the addition of something like, as you mentioned, hydroxychloroquine to methotrexate can just be that little push that they need to just switch off that inflammation and get them into remission. Similarly, we know from the studies that actually for a lot of the biologics, you do get an added benefit from patients that are on combination treatment rather than on monotherapy with just the biologic. Particularly this goes for the anti-TNFs. We know that it improves the longevity of response in some instances with the anti-TNF, so that patients they've initially responded to an anti-TNF drug. The addition of methotrexate and continuing their methotrexate will ensure they don't develop these things called anti-drug antibodies, where we can see a loss of response. So we make sure that once they're on the right drug for them, it keeps working for them. So all in all, I would say that combination drugs is the norm, and it's nothing to be concerned about. Obviously, your rheumatologist will be managing these combinations carefully.
In terms of how these drugs are administered, obviously I know they can be taken orally or as a subcutaneous injection. Is one better than the other in terms of absorption rates? Or how do you come about making that decision with your patients in terms of, obviously some drugs they're just orally taken. How do you, as I said, go about just coming to that kind of conclusion of deciding on the drug?
So obviously patient preference is a big thing. So I suppose the first thing to say is when you talk about this question, I automatically think of methotrexate because that's the one where I think there's the most option for both. A lot of the older drugs are just available as tablets, and a lot of all the biologics are just available as injections. And then we have these smaller targeted therapies such as the JAK inhibitors, which are tablets only as well. But in the case of options, so thinking about methotrexate, patients will generally start on tablets. Most patients will have a preference for taking a tablet over an injection. And we know that doses up to 15 milligrams, there's probably not a lot of difference in absorption. But at the higher doses of methotrexate, we know there's a slightly better bioavailability at the high doses of 20 or 25 milligrams by taking it subcut. The other thing is that if patients are getting GI side effects, so feeling nauseous or any diarrhea or things from the tablets, switching onto the subcut injectable version in the majority of cases will alleviate those symptoms. So quite often we will switch for improvement of side effects, and sometimes we'll switch if we're concerned that there's an issue with absorption.
Okay. And do you find that people are nervous about the idea of injecting themselves, or does that just, they get used to that very quickly?
Obviously, it depends on the patient.
Yeah.
So, we have some patients who've coexistent diabetes who are injecting themselves all the time, and it's not a bother. Whereas you have a needle phobic patient and it's their worst nightmare.
Yes.
So it's a complete spectrum. But I think that our rheumatology specialist nurses and some of the companies also that provide these biologic drugs also offer services. So I think there's a lot of support from nurses in the bringing the patients on the journey, getting them used to doing the injections. So although it can quite often seem daunting, once you see patients back in clinic and they've got used to it, they really don't have a problem.
Yeah,
most
they don't
of the
blink,
time.
I'm sure.
No.
Yeah, exactly. Okay, I know in the past steroids were frequently used to treat arthritis as kind of a first line, and they were used over a long treatment period. And there's been a change around thoughts around steroids, side effects and long-term use. Could you share with us some of the new thinking around the use of steroids for treating arthritis, please?
I can indeed. So, steroids are both our best friend and our worst enemy in terms of they are very effective for treating inflammation very quickly, and they work across the spectrum of a lot of our inflammatory rheumatic diseases, pretty much all of our inflammatory rheumatic diseases. So there's definitely still a role for steroids, but unfortunately they also have serious significant side effects, which are sometimes even underestimated. So if someone presents with new rheumatoid arthritis or very inflamed or new psoriatic arthritis, we may use steroids. We generally will use steroids in the initial phases while we're waiting for some of these disease-modifying agents we've talked about to take effect, because they are slow acting and they take weeks to months to really optimize. So steroids are great because they get patients back moving and feeling better and you get your little steroid high. But in terms of side effects, in the long term, we know that there's risk of osteoporosis, which our patients are at risk of anyway. So we don't want to exacerbate that. There's a risk of diabetes, increasing their blood pressure. Again, cardiovascular risk in rheumatoid is something we're cognizant of, so we don't really want to be aggravating with steroids. And then I think another thing that is underestimated, we're all very aware of the risk of infections with our new biologic drugs, and everyone's very cautious. But actually, particularly high dose long-term steroids are probably as much, if not more, of a risk. And people don't necessarily recognise that. But steroids are really overall not good for you. So yes, they 100% have their place, and we'll use them for flares and we'll use them for getting things under control in the initial phases. But really, they shouldn't be a long-term option in modern rheumatology, given all of our new options.
Okay, thank you. And you mentioned there about, a kind of a delay in some of these biologics starting to work. You might just tell us about that in terms of some of them take weeks, some of them take months. Do you find it's difficult with patients because they're obviously experiencing a lot of symptoms? They need to be very patient, using that word, patient. How do you experience that as the prescriber?
Yeah, so everyone is individual, and some patients will respond really well to the first medication, and you give them we quite often use intramuscular steroid little injections, and by the time that's worn off, their main drug has kicked in and they're great. Whereas other patients unfortunately have a bit more of a tortuous journey, and there is sometimes a trial and error getting people to the right combination that works for them. But I think it's something we're very cognizant of with the advent of early arthritis clinics, and we know that we want to see anyone with new rheumatoid, new psoriatic arthritis, new spondyloarthritis as soon as we can to really get in early in the disease, and that way we should have a quicker response. And certainly one of the outcomes we'd look at generally in studies would be remission at 1 year, and that would be our goal, is to get everyone back functioning on their medications without stiffness, without pain, without tender and swollen joints, and back living their lives.
Well, that sounds really positive. So you just mentioned there about early intervention. I'm interested to ask you about that. So I know this has a bearing on how effective medications can be in switching off the inflammatory response. So is it a matter of it when somebody comes a bit late to you, say they've maybe had symptoms for, 7 or 8 years, is it just a matter of it taking longer for the medications to work, or will those medications never be as effective as they would be in somebody if they had come very early to you?
Yeah, unfortunately, we do still see the occasional patient where there has been diagnostic delay or they haven't been referred. So we do talk about this window of opportunity in early disease where the immune system is in this early turned on stage that we try and switch off. And sometimes when that becomes more established over the course of more long-standing disease, it can be more challenging to actually target the inflammation, particularly at that point. Not only is there inflammation that we need to control, but if they've had chronic inflammation, particularly over years, there may be also damage to the joint. And once damage happens, it's irreversible. So again, that's part of the reason that we really want to get people in early before they start to damage their joints and get things under control so that it doesn't become a long-term problem for them.
Okay, so really early intervention is so key.
It's absolutely key, and it's been made one of the priorities on the model of care for rheumatology nationally. So it's something that we're really striving to achieve nationally.
When we talk about medications, we often are talking about side effects, and every medication will have potential side effects. With the medications used to treat arthritis, we know that some that people would be particularly nervous about would be side effects relating to eye health, say hair loss, photosensitivity, or you mentioned before gastrointestinal side effects, stomach issues, diarrhea or nausea. How concerned should people be about these potential side effects? Or how common are they? Or can we go into maybe how they are managed and your experience of that, please?
So I think obviously benefits should outweigh the risks, and not every drug is going to be suitable for every patient. But the majority of our drugs, despite what the scary information about the drug says, are very well tolerated. And the majority of our patients on the majority of medications don't have significant side effects. So I might unpick this a little bit because you've mentioned a few specific things, and I think those are relation to specific medications. So I suppose the first thing you mentioned was eye health. We know that with long-term use of hydroxychloroquine that you can get a deposit on the back of the eye that can affect vision. Now, obviously that sounds like a very scary side effect, but it's something that we've become very aware of. And we screen for now on a regular basis, particularly with the advent of the OCT or these ocular CT scans, which show great detail on the back of the eye. So we would pick anything up very early with that. Mm. Again, it's also a dose-related and duration-related effect. So for patients starting out on these drugs, we now we base the dose now based on the patient's weight, based on their kidney function. And again, with this close screening, it's not something that patients should be concerned of because it's something that, yes, if it were to happen, would be serious, but it's rare and it's monitored for. And then moving on, I suppose, to things like hair loss and tummy upset, I suppose our primary culprit for that is probably methotrexate. And certainly people will get some tummy upset initially when they start the drug, which is why we generally start it at a low dose to get your body used to it, and then we will increase it up. The majority of patients don't run into problems with this, and if they do, we've mentioned already about the injectable form, which can bypass the GI tract, and generally that will resolve the issues. The other thing about methotrexate is that we give it with folic acid given generally, there's various regimes, but generally a different day. So the day after the methotrexate or a few different days. And sometimes if people are getting side effects, we might give them folic acid 6 days a week. So there's different regimes of increasing the folic acid to reduce the risk of any side effects with methotrexate. And that goes with the risk of having abnormal liver function or it affecting your blood tests. So obviously patients need to be educated about these drugs because there's potential for that. But in reality, the risk of it is very low. Mm-hmm. And then I suppose specifically about the biologics, that we need to make sure that patients are educated because the biggest risk probably with them is atypical infections, and sometimes that they won't necessarily, because their immune system is suppressed, they won't typically present with the typical symptoms that you might get with an infection. So that we would always counsel patients and advise them that if you aren't feeling well, to seek medical help early when you're on a combination of these drugs. But generally, most side effects can be managed, and patient education and awareness of them is key. But
Yeah,
it's never as bad as it sounds.
exactly. I know. And you touched on that there is closely monitoring patients. So in terms of doing full blood counts, liver function tests, they're frequently done throughout the journey of when you prescribe a new medication. Typically would that be followed up, 6 months later? It depends on the medication probably.
So again, it depends on the medication. And generally, if patients are going to run into a problem, it's generally early on. So when we initiate treatment, particularly with drugs like methotrexate, we will do quite regular blood monitoring over the first couple of months while we're initiating and escalating the treatment. And once patients are more stable, then that can become less frequent. So 3 monthly generally would be the advice for methotrexate. And certainly on the biologics, we'd want to be checking them certainly a couple of times a year, depending on the patient's individual circumstances, obviously. The other useful point to, I suppose, monitor about the blood tests, we're monitoring for safety in terms of the blood count in the liver, but we're also looking at the inflammation markers to make sure that the disease is controlled. So it's giving us more information than just, yes, it's safe. It's also telling us,
it's working.
It's working.
Excellent. Yeah. Okay. Right, so moving on to a slightly different topic. When it comes to the way things are done these days, traditionally we know that we've all experienced in the past, or we've heard our mothers talk about, is the doctor very much telling you what to do, the person going away and doing it. Whereas now, especially around arthritis, we're hopefully partnering with the health professionals and the rheumatologists like yourself. And we're encouraging as an organisation, Arthritis Ireland, that people are very much involved in the decision-making process around, medications and so on. Do you find that helpful? And what do you find, like for instance, if somebody comes in with a symptoms diary, is that extremely helpful for you? And how do you see this kind of partnering with the patient?
Yeah, so I think that's absolutely key. And I think we're definitely moving away from this model of the paternalistic doctor handing you the script. And it's great that patients can be empowered to manage their own condition. And if they understand it, they're going to manage it better. So 100% we really encourage that. And the work that Arthritis Ireland doing is brilliant in supporting patients for that and helping them manage their disease. Because obviously, I know this is about drugs, but a lot of what our arthritis patients have to manage is nothing to do with drugs. It's to do with lifestyle and exercise and all of those other facets of their lives that their arthritis can affect. So yes, symptom diaries are helpful. I mean, I think internationally there's a move, not just in rheumatology, but across all medical specialties with e-health and the advent of apps and things that we would be recording outcome measures. So EPROMs is kind of the trendy word at the moment. So electronic patient reported outcomes. And this is a great help because it allows the patients to input their symptoms and their flares over time. And then they can see them, but also when they come to clinic, they might come, quite often patients come to see us and they're quite well. But actually when we look back over how they were 4 months ago, they might have had a massive flare up that they've maybe forgotten. But if we have these EPROMs, then it's really helpful to know that maybe they're not quite as well as they thought. And maybe we do need to look at tweaking things a little bit for them. So I think, that is really good. I mean, certainly in the early phases of their disease, we'll be seeing them regularly to make sure things are under control. But as patients are living well with their chronic condition, and they don't need to be dragged back to the hospital, and we're looking at implementing things like patient-initiated review where they come on a needs basis rather than a automatic 6-month basis, which is one of the things that the HSE are bringing in. We want to make sure that if they're out there, that we've got some feedback to make sure they're managing and then that they're not struggling. And I think these PROMs, patient reported outcome measures, or symptom diaries, or e-versions of same are really helpful for both the patient and for us as their rheumatology team.
And it is really helpful for, I think, encouraging that the patient is taking responsibility for their own care as well. Yeah,
Absolutely.
So can we move on to covering off maybe some of the medications that are not recommended in certain cases? So obviously pregnancy is one, or if somebody's diagnosed with cancer, for instance, I know that sometimes they're taken off a certain medication and moved on to another. You might tell us a little bit about that, please.
Yeah, so certainly pregnancy, obviously, the ideal thing is that we would have, with our MSK patients, our rheumatology patients, that we would have planned pregnancies. So if a woman of childbearing age is keen to have a child, we will have that discussion with them, and we're very happy to have that even well in advance of planning of conception in terms of making sure that their disease is optimally controlled and that they're off any drugs that could be putting them at risk when they become pregnant. So I suppose the classic one would be methotrexate. We would make sure that women of childbearing age are off it for 3 months before they start to conceive because it causes fetal abnormalities, amongst other things. So we would switch them on to something else, and then the other drug, I suppose thinking of the classic drugs, would be leflunomide, which is something that we would generally try to avoid, unless there was a very good reason in a woman who hasn't yet completed her family or who's planning on having children, because it's got a very long half-life and it can take up to 2 years to get out of your system. Okay. So that's one that we would try and hopefully not avoid. Sometimes patients, in specific circumstances, patients may end up on this. So those would be our main two ones. And then when we look at the biologics, again, there's a lack of evidence. So obviously, a lot of these things historically would be wary, but now we feel that it's quite safe to use anti-TNF early in the pregnancy, and then we will tweak things as things go on. Steroids are very safe in pregnancy. Hydroxychloroquine is safe in pregnancy. Sulfasalazine is safe in pregnancy. Azathioprine is safe in pregnancy. So we do have a combination that may not be what we'd have the patients on long term, but there's certainly outcomes. There's options there for patients so that we can see them through the peripartum period and manage them. Some patients will have a great pregnancy where their rheumatoid goes into remission. That was kind of classical teaching, but unfortunately it's not true for everyone. So, being with the patient and on that journey is key, and making sure that we've got good contact with them. You've also mentioned then other conditions, so around cancer. So a lot of the time patients are having chemotherapy. Chemotherapy is basically obviously wiping out your whole immune system. We're just dampening down with our drugs. So generally, if people are going through chemo, the chemo will nearly do what we're doing, but with a wrecking ball. Yeah. So we would generally stop the medication while people are on chemotherapy. Some of these immune therapies now that are being used for cancer, though, can either cause a rheumatoid arthritis-like picture, or it can cause a flare of rheumatoid in patients who have known rheumatoid. Okay. And so that's something that we do manage, and that's been an emerging thing over the last decade. But again, that's something that actually now we do manage with things like methotrexate and anti-TNF, which historically there was a warning if someone's had anti-TNF. If someone's had cancer, you don't give them anti-TNF. But the thinking has changed, and as more evidence emerges, we know that these are very individualised cases, obviously, but as a general thing, it would be stop during chemo and then we manage after. And the majority of things, we would put people back on, but with a few exceptions. And again, depending on individual circumstances. Yeah.
And again, it can sometimes, I think we mentioned that previously, but sometimes when I know of somebody that they had cancer and then they went back on the medication that they were on previously, but it wasn't working. So it can sometimes be, as you said, trial and error to find the one that's going to, dampen down their rheumatoid disease again. Yeah. And let's move on to things like alcohol and smoking. So does alcohol react with some arthritis medications? And what is your advice around this?
So yes is the answer. So I suppose, again, the common thing that we would worry about, because it's probably our most used medication, is methotrexate, mainly because it can have effects on the liver. And as we all know, alcohol can affect your liver. So the combination can be a little more damaging. So we don't say to patients that they have to stop alcohol completely, but they really need to cut right down if they are drinking beyond recommended limits. So we would certainly advise, yes, you can have a couple of drinks, but not beyond recommended limits. And obviously that you'd have your blood test monitored. Thinking, I suppose, the main condition that we worry more about alcohol rather than in rheumatoid would be, I suppose, our gout patients, because we know that alcohol is a big trigger for gout flares. It's a risk factor for developing gout, and then it can exacerbate gout if you have it. So, I suppose an alcohol history and cutting down for our gout patients would be really key in that population.
Yes. And what about smoking? I know that it apparently can interfere with the effectiveness of some medications. So is that another part of the advice that you give.
Yes.
Yeah.
So we might be not so worried about alcohol, but we really do not like smoking in rheumatoid. So we know that smokers, patients with rheumatoid arthritis who continue to smoke have worse outcomes. So that's in terms of their joint, in terms of the response to medication, in terms of other involvement. So rheumatoid arthritis can affect your lungs, and the risk of rheumatoid lung disease is increased in smokers, as well as you mentioned, the medication just not working as well. So that's one thing that we really counsel our patients, that you really need to try your best to stop smoking, as well as obviously the lung cancer risk, the cardiovascular risk. And again, as I mentioned earlier, our patients are at increased cardiovascular risk. So if you're adding smoking into that on top of their inflammatory disease, it is a bit of a disaster. So smoking cessation is absolutely key.
Okay. And what about overweight and obesity? If somebody's carrying a lot of extra weight or they're in the obese category, what is that going to make the drug therapy less effective as well?
Unfortunately, yes, it is. So, obesity is also a pro-inflammatory state, and there's been studies done looking at this, that we know that the medications don't work as well, particularly the anti-TNFs. Now, sometimes there's ways to mitigate that, in terms of some drugs can be weight-based, where we can give a slightly higher dose to try and achieve remission, but overall the outcomes are poorer. So if patients are overweight, trying to address diet and lifestyle in terms of getting the weight down, not only from the point of view of their inflammatory disease, but actually from mechanical stress on the joints. So if you think about that extra pressure, particularly on their lower limb joints, in developing secondary osteoarthritis. So smoking and overweight are definitely not going to help you. So those are two key things to address if they're issues for a particular patient.
I had a question about treatment. When a patient comes to you, Jo, and say they're just maybe determined that we're not going to take medication, and as I said, Arthritis Ireland, we are an organisation that's all about self-management, which is all the lifestyle factors, as you mentioned before, diet and exercise and stress management and so on. But medication does have a role to play. For somebody who, I'm thinking of myself here in terms of a back issue I had at one point, and I was determined not to take anti-inflammatories for some reason and got myself into a bad condition. But when I did go to the consultant, he did say to me, you need to take the anti-inflammatories to get the inflammation down in your body. So do you come across somebody that's quite stubborn and doesn't want to, they have their own reasons for not going on medications, and how do you experience that? Or is it very much up to the patient and you respect their view and that they're going to try and manage it without medication? Or is it a case of kind of trying to encourage them? And it depends on the individual and the case, of course, but you might just let us know anything about that.
Yeah, so obviously we always respect patients' decision, and at the end of the day, nobody's going to force anyone to take something they don't want. But I suppose we've been on the other side, where we've seen the consequences of not taking the medication. And we've also seen the historic cohort of patients who didn't have the option of those medications, who have come to our clinics, when people have this old idea of what rheumatoid was, people in wheelchairs, every joint replaced, deformity, all of those awful things that we used to see in the past. And thank God that with the advent of these modern therapies we've been talking about, and the change in how we treat it, that thankfully is a rarity, if not, should be obsolete now. So when you're sitting on the other side of the table, on my side of the table, the idea that you would let someone get to that point is incredibly difficult. So with respecting, obviously, people's things, sometimes people need time and education, and they may not want it that day, but I think giving them time and giving them a session with the nurse to kind of go through the questions, getting the support of Arthritis Ireland, of getting support of other patients, I think can be a really powerful thing for patients, to see what other people have gone through. But certainly it's quite common that people say, I don't want to take a painkiller. And I suppose that's fine. You don't need to take a painkiller because that is a temporary effect. Whereas the drugs that we're giving, they're doing something different. As we said, they're disease modifying and they're switching this off. So it's not just about the pain, it's about the inflammation and the damage that, if it's left unchecked, will cause problems for them down the line. And I suppose that's what we're really keen to avoid, especially since we know from all of the literature that this early intervention, it really improves the long-term outcomes. And we want these people to be living full lives and working and enjoying their hobbies and not stuck at home with pain. And there is a massive role, and the patients that do help themselves with diet and exercise and lifestyle modifications, do well. And a lot, like anything, the right mental attitude is key. Yeah. But unfortunately, depending as well on the severity of your disease, again, it's a spectrum. But, someone with markers for severe rheumatoid, we really, the drugs do work.
Yeah, exactly. A combined approach, as you said.
Yeah.
Okay, so coming to my final question, what do you see as being on the future horizon in terms of new treatments? Can you tell us a little bit about that? And what can somebody listening to us today living with inflammatory arthritis, what can they feel hopeful or excited about, say, in the next 5 to 10 years, if something's coming down the track then, or it might be a bit longer than that?
Yeah, so I suppose, there's a lot of talk now about stem cell treatment and CAR T cell therapies and all these immune modulations that we're looking for a long-term, I suppose, a cure really for rheumatoid arthritis. And I think certainly at the moment they can be hopeful that if you were to develop rheumatoid today, that we have a whole armamentarium of great medications that, we can get you on. And for, as I said, it's a case of sometimes finding the right one. And there is sometimes a bit of trial and error. I think what we're trying to move to in the research area is looking at trying to do this personalised, individualised medicine. So rather than saying, right, we're going to choose biologic X for you, we'll be able to do some more specialised testing and say, well, actually, based on the personalised tests we've done, we think that biologic Y would work better for you. So this era of personalised medicine where we try and get it right first time, rather than, as you said, some patients end up on a journey where the first one doesn't work and then we try the second one. And, if we can get it right first time, then obviously that's great for the patient. Down the line, I'm not sure we'll be having CAR T cell therapy for all and stem cell therapy for all in the next 5 to 10 years. But I think certainly within our lifetimes that, there will be lots of hope on the horizon. But I think, now it's a very positive time in terms of what we have available to treat rheumatoid, psoriatic and Angst-Bond.
Yes,
So
as you said, I think we're in a really good
Yeah.
position right now, and there's so much to be hopeful for today rather than thinking too far into the future. And there's so much, it sounds like, that diseases like arthritis can be managed so well with these medications. So thank you so much for all this insight. It's so fascinating and there's so much to learn, and I'm sure everybody really enjoyed it. So thank you, Jo, for your time.
No, you're very welcome. Thank you very much for having me.
That's all from this episode of Inflammation Nation. Don't forget to subscribe on Apple Podcasts, Spotify, or wherever you get your podcasts. For more information about arthritis, please visit our website, arthrititsireland.ie, or contact our helpline on 0818 252 846. Inflammation Nation is supported by Pfizer and AbbVie.